So hi everyone. So I am Dr. Vivek, the mentor study medic. Today we are going to conduct a marathon session regarding the applied surgical science and critical care. So this is a very important areas for the Part B MRCS, and everyone should have a good knowledge and good practical approach about this. So I'm starting with a quote, that is, the hard work with dedication and along with consistency will take you into the success. So this is the session agenda. I will be talking about the critical care station and framework, the fluids and electrolyte and acid-base balance, the shock and about the deteriorating patient, and about the sepsis, that is the sepsis 6 management, and something about the trauma, that is ATLS, fast, and the lethal triad, the acute pancreatitis and its severity, the post-operative complications, and some aspect about the nutrition, the acute kidney injury and respiratory failure, and regarding the transfusion, burns and glycemic control, and finally question answer part that include the spot and recall pearls. So actually the critical care station testing our ability about the safe, systematic and the resuscitation first approach. So this is a key thing you have to keep in your mind. Sometimes we may have to analyze the arterial blood gas chart, a fluid balance or drug chart, a trauma, a scenario regarding the trauma, about the trauma, or a scenario about post-operative surgical management. And also they may display some sort of imaging related to this station, or they can display chest X-ray or some blood reports. And this station actually works in a way that you have to always resuscitate before you diagnose. That is a very key word you have to understand. That is, you have to resuscitate before you diagnose. And always you have to give the dose, the targets and threshold. Suppose if you are planning to give some drug, if you are planning to say regarding a drug that is used in the treatment of a particular condition, sometimes you may have to reveal the dose. And suppose if that particular condition, sometimes you may have to grade that condition based upon some non-severity scoring system. And also you have to state when to escalate the problem, the situation to the senior or to the ITU, and always in a safe, structured and decisive manner. You have to follow this. So we are going to discuss the framework of this station, the critical care scenario station. So first is the always resuscitate. Suppose any scenario regarding the applied surgical science, you have to always start by saying that I will manage this patient according to the care of the critically ill surgical patient protocol, and I will resuscitate according to ABCD approach, that is airway, breathing, circulation, disability and exposure. So always start answering by like this. Okay. Then you have to assess the something, that is you have to take a focused history, the examination part and the monitoring part. You may have to investigate, that include the blood investigations, the cultures, the arterial blood gas analysis, imaging. Then comes the diagnosis and the grading of the problem. I have just recently told that if there is a severity grading scoring system exists, obviously you have to grade the severity. Then comes the definitive care. That is about the source control, and you have to support the other organ systems. And you have to keep in mind when you have to escalate the problem to senior, to ITU, or to the multidisciplinary team. Like I have already said, always start with, I would manage this patient according to care of the critically ill surgical patient protocol, and I will conduct the resuscitation according to ABCD approach. And obviously, if the problem is something complex, obviously you can mention that I will call the senior for help. So always you can start like this. So you have to understand some basic idea regarding the fluid compartment and maintenance. As you know, the 60% of the body weight is constituted by water, and this water is distributed as the intracellular compartment and also to the extracellular compartment. The extracellular means anything outside the cell, that include the interstitial compartment and the plasma. About the 3/4 constitute the interstitial compartment, and around 1/4 constitute the plasma. So the maintenance fluid required is the 25 to 30 ml per kg per day. So that is the daily requirement according to the NICE guidelines. So regarding the electrolytes, that is the sodium, potassium, and the chloride, the daily requirement is about the 1 millimole per kilogram per day. The average glucose requirement is ranging from 50 gram to 100 gram per day. And always you have to reassess the losses, the deficit, and you have to give the fluid accordingly. And the key aspect is always describe the maintenance fluid, the replacement fluid, and the resuscitation fluid separately. You never lump them together. So something about the crystalloid and colloid resuscitation. The balanced crystalloid or Hartmann's solution you can use as a first line resuscitation and maintenance fluid, and you have to be very cautious because it contains potassium, so it is better to avoid in situation where the patient is already having hyperkalemia. Second one is the 0.9% normal saline, that is again can be used as a fluid in resuscitation. But remind one thing, that the larger volume infusion of this 0.9% saline can cause the hyperchloremic acidosis. Next is the 5% dextrose, that is used for a free water replacement, that is not for resuscitation. Suppose if there is a situation of hypernatremia, you want to give some free water. So in that situation, you can use the 5% dextrose. Finally, the colloid or albumin. These are the plasma expanders, and their use is limited to certain selected cases only. So always resuscitate with 250 to 500 ml of bolus of balanced crystalloid and reassess later on. And always you have to assess the signs of hypovolemia, that is the tachycardia. The peripheries will be cool. If the patient is conscious and the patient experiencing some thirst, and the urine output will be low, that is less than 0.5 ml per kg per hour. On blood examination, the lactate will be elevated. So something about the sodium disturbances, that is the sodium imbalances. It could be either the hyponatremia or hypernatremia. The causes are different. The hyponatremia, the causes include, one is CR secretion, excessive use of diuretics, fluid overload, and the patient with hyponatremia is at risk of developing cerebral edema and seizures. And how will you correct the hyponatremia? So you should always correct the hyponatremia in a slow manner. The rapid correction of hyponatremia can lead into osmotic demyelination. That is, the correct the sodium slowly, that is about less than 8 to 10 millimole per liter in a 24-hour period. The rapid correction can cause central pontine myelinolysis. So regarding the hypernatremia, the causes could be the dehydration or the diabetes insipidus, and the patient is having risk of developing cerebral edema. About the potassium disturbances, it includes the hyperkalemia and the hypokalemia. So the hyperkalemia can be identified based on some ECG findings. The T wave is usually believed will become tall. The QRS complex will become wide. If there is a persisting hyperkalemia, the ECG can change into a sine wave pattern. And you should know something about how to manage a case of hyperkalemia. You can give injection calcium gluconate. Its role is the cardioprotection. And always you should give the insulin along with the dextrose. And also the nebulization with salbutamol. These two measures, that is the insulin along with the dextrose and the salbutamol, will cause the decreasing potassium in the blood. And finally, you can use some resins, or you can consider the dialysis, that is to remove the potassium from the blood. So regarding the hypokalemia, the ECG will be, the T wave will be flat and the U waves appears. So what could be the causes of the hypokalemia? The potassium can be lost through the GIT or the extra GI way. So how will you replace potassium? You have to give the potassium and correct the magnesium also. So that is a very important point. Suppose the patient may be having some sort of potassium disturbances, and always you have to check the magnesium and correct the magnesium also. The hypokalemia can produce some sort of risk regarding the arrhythmia. It can cause cardiac arrhythmia. So in hyperkalemia, the calcium gluconate stabilizes the myocardium but does not lowering the serum potassium level. For that, you have to give the insulin along with the dextrose. So regarding calcium and magnesium, the calcium may be increased, that is hypercalcemia, or the calcium level may be decreased, that is the hypocalcemia. The causes are different. Suppose a patient is underwent thyroidectomy, the patient is having the increased risk of hypocalcemia. It may be due to sometimes the accidental removal of the parathyroid along with thyroid, or it may be also due to decreased blood supply to the parathyroid post surgery. Sometimes during thyroidectomy, the blood supply to the parathyroid may be lost, that is coming from the inferior thyroid artery. So that can cause the hypocalcemia. So how will you identify a hypocalcemia, a patient with hypocalcemia? The patient will complaining of some numbness, that is in the perioral region, or sometimes some patient complaining of numbness in the extremities. So you can elicit some signs in patient with hypocalcemia. First one is the chopstick sign. That is, you are tapping the preauricular area and the patient is having twitching in an area that is correspond to that face. That is a preauricular area. The facial muscles twitching will be there. And obviously you can also demonstrate the Trochu sign. The patient also having tetany. So what about the hypercalcemia? So the hypercalcemia may be due to different causes. First one is the hyperparathyroidism. The hyperparathyroidism may be due to the parathyroid hyperplasia or parathyroid adenoma. And the hypercalcemia is also associated with certain malignancy because the parathyroid hormone related peptide that is increased in circulation, and that can cause the hypercalcemia. So what about the magnesium? Suppose a patient is having refractory hypokalemia, you always check the serum magnesium and calcium also. And always you have to supplement the magnesium before correcting potassium or calcium. The causes of low magnesium include the gastrointestinal losses, excessive diuretic intake, and also excessive alcohol intake. These all can cause the decreased magnesium in this blood. So the key point is the potassium won't correct until the magnesium is replaced. So always check and replace magnesium before you are correcting the potassium. That is a very important aspect. Next, we are going to discuss about the analysis of an arterial blood gas. first part you have to look the oxygenation status. You can look the PaO2 or FiO2. The second one, you have to consider the pH. As you all know, the normal pH, you can take a cutoff of range of 7.35 to 7.45. For a calculation purpose, you can also take it as a value in between, that is 7.4. Suppose if it comes less than 7.35, that means it is an acidosis. And if the pH is more than 7.45, that is alkalosis. Then comes the respiratory aspect, that is the PaCO2, that is controlled by the lungs. The metabolic parameter, that is a bicarbonate or the base excess. And the fifth aspect, you have to look for the compensation. And if it is a metabolic acidosis, you may have to calculate the anion gap also. So how to identify which type of metabolic problem from the ABG? Initially, you have to look the pH value. If it is less than 7.35, that is acidosis. If it is more than 7.45, that is alkalosis. Then you have to ask whether the carbon dioxide, that is CO2, PaCO2 or the bicarbonate value, which one is deranged. According to that, we are able to distinguish whether it is a respiratory problem or it is a metabolic problem. If carbon dioxide is not in the normal range, it could be a respiratory problem. Or if the bicarbonate is in abnormal range, it will be the metabolic problem. So this is the way in which you are to identify, or you have to analyze a arterial blood gas report. So the acidosis, that is a high anion gap acidosis. The causes could be excessive lactate. That is, suppose a patient is having sepsis, obviously the lactate level will be increased. That can cause high anion gap acidosis. The ketones, a scenario like the diabetic ketoacidosis, the patient is having high anion gap acidosis. Then the urea and also the toxins. So what about normal anion gap acidosis? Normal anion gap acidosis, that is seen in case of bicarbonate loss, either through the gastrointestinal route or through the kidneys, and include the renal tubular acidosis and the diarrhea. So what about the metabolic alkalosis? So the metabolic alkalosis, the causes could be the vomiting, the nasogastric losses, and the diuretic. Suppose if the patient is having excessive vomiting, as you all know, the gastric secretions contain the hydrochloric acid, and the H plus is lost, or H plus is lost as the patient is having continuous vomiting. So the patient is developing alkalosis because H plus is acidic and that is losing. That means the patient is becoming alkalotic. And also the diuretic, excessive diuretic intake can also cause metabolic alkalosis. And always you may have to, not always, you have to calculate the anion gap. Also, how will you calculate the anion gap? That is the gap, that is the difference between the measured cations and the measured anions. Measured cation means that is the sodium. Measured anion means that is the chloride and the bicarbonate. Suppose a surgical patient is having rising lactate. So that is an indicator of the tissue hypoperfusion, because if the tissue is hypoperfused, the metabolism is changed from the aerobic into anaerobic metabolism, and the lactate is accumulated as a result of anaerobic metabolism. So rising lactate in any surgical patient, that is indicate the tissue hypoperfusion until proven otherwise. And always you have to start with the resuscitation, and then you have to find the source. So that is an exam tip. So now we are dealing acid-base disturbances based on some example. First, about the respiratory, that is the acidosis. That is increased carbon dioxide. Alkalosis, that is the decreased carbon dioxide. Suppose a patient is having hyperventilating. Hyperventilating means the ventilation is increased. That can cause the carbon dioxide washout. Or if the patient is having excessive pain, or patient is having pulmonary embolism, these all can cause the alkalosis. And hyperventilation, the COPD patients and the excessive opioid intake, this can cause acidosis. So always you can identify the degree of renal compensation, and you can categorize into acute or chronic. And we are dealing with some example. The pH is 7.28, the PaCO2 is 2.9, and the bicarbonate is 30. The pH is 7.28. That means the patient is having acidosis, because the pH is less than 7.35. Then the bicarbonate level. So what about the normal bicarbonate level? You can take a set around 22 to 26. Here the bicarbonate is low. That means it's a metabolic. Here the carbon dioxide is also low. That means the patient is compensating by altering some respiratory pattern. So the respiratory compensation will occur immediately, and the metabolic compensation will take some time. So what is the diagnosis? And here the lactate is also 6. So what is the diagnosis? The high anion cap, so the lactate, the high anion cap, the metabolic acidosis. So always you have to remember that the kidneys will compensate. Kidneys will take some 1 to 2 days, and the lung will respond in minutes. Next, we are going to discuss about shock. Shock means it is the tissue hypoperfusion. So any sort of tissue hypoperfusion you can consider as a shock. There are different types of shock. The hypovolemic shock, the distributive shock, the cardiogenic shock, and finally the obstructive shock. The hypovolemic shock means the circulating volume is decreased. It may be due to some hemorrhage, or it may be due to some non-hemorrhagic causes. The hemorrhagic cause means, suppose a patient is having some sort of trauma, and the patient is experiencing some sort of bleeding into the peritoneal cavity, obviously that can cause the hemorrhagic shock. Here the blood is lost. So what about non-hemorrhagic type of hypovolemic shock? Here not the blood is lost, but the body fluid is lost. One example could be the burns. The body fluid is lost in burns, that is into the tissues, the extracellular space, and the GI losses, gastrointestinal losses. Suppose a patient is having diarrhea or vomiting, and the patient is losing the fluid through the vomitus or through the diarrhea. Obviously, that can cause the hypovolemic shock. So what about the distributive shock? Distributive shock means it is in problem related to the distribution, that may be due to vasodilatation, and that is seen in sepsis, anaphylaxis, and the neurogenic shock. The neurogenic shock, the vessel tone is lost and the vessel is becoming the vasodilated state. So that is about the distributive shock. So regarding the cardiogenic shock, the heart is pumping the blood. So any abnormalities or any problem with the normal pumping of the heart can cause the cardiogenic shock. Like suppose if the patient is having arrhythmia, or if the patient is having myocardial infarction, the heart is unable to pump properly, that is called the cardiogenic shock. Next, about the obstructive shock. Obstructive shock means any obstruction to flow, that is outflow from the heart, that can cause obstructive shock. The causes could be different. First, about the cardiac tamponade. Cardiac tamponade means it is accumulation of blood in the pericardial space. So what happens? The heart is not able to relax properly. And what about the tension pneumothorax and the pulmonary embolism? These two can cause obstructive shock. And in a surgical patient, the shock is you have to consider as a hypovolemic shock until proven otherwise. Suppose if you are ruled out to the hypovolemic shock, then obviously you have to look for the other causes of shock like the sepsis or anaphylaxis, etc. So how will you distinguish between distributive or septic shock from the hypovolemic or cardiogenic shock? In distributive shock, the peripheries will be warm and the pulse will be bounding. So what about the hypovolemic or cardiogenic shock? The cold, thready, the extremities will be cold and the pulse will be thready in a case of hypovolemic or cardiogenic shock. So this is a classification that's based upon the ATLS. The hemorrhagic shock is classified into class 1, 2, 3, 4. That is based on the amount of blood is lost. Is the less than 15% of blood is lost, that means that is a class 1 shock. In class 2 shock, the patient is losing little bit more of blood, that is around 15 to 30% of the total circulating blood volume. In the class 3 shock means the 30 to 40% of the blood volume is lost. And finally, class 4 means anything that is more than 40% of the blood volume is lost. That patient comes under class 4 shock. So how will you distinguish the class of shock based upon the heart rate, blood pressure and mental state? In a class 1 shock, the patient's heart rate is usually less than 100. In a class 2, the patient is experiencing tachycardia. That is, the heart rate will be in the range of 100 to 120. In class 3, the heart rate is increasing further. That is around 120 to 140 beats per minute. And obviously in the class 4 shock, patient is experiencing the maximum tachycardia, that is more than 140 per minute. What about the blood pressure? In class 1 shock, the blood pressure is normal. And the class 2 also, the blood pressure is normal. And the class 3 and class 4, the blood pressure is reduced. So from these, you have to understand one thing, that sometimes the patient might lose around 25% of the blood and the patient's BP may be normal. So you cannot take blood pressure as a sole parameters to detect the extent of the hemorrhagic shock. And regarding the mental state, in class 1 and class 2, the patient will be anxious. In the class 3, the patient is confused. And in a class 4 shock, the patient is lethargic. So the key pearl is the blood pressure falls late, that is in the class 3. So tachycardia and narrowed pulse pressure are the early warning signs. So I have told the class 2 shock onwards, the patient is developing tachycardia. That is, the pulse rate is gone beyond 100 beats per minute. And exam tip is the healthy young adult will compensate well, then crashes suddenly. So I'm again like to highlight the don't be reassured by a normal blood pressure. The patient might lost up to 30% of blood before developing hypotension. So that is a very important point you have to keep in your mind. So what about the shock management? So always you have to conduct the resuscitation. That is in the ABCD protocol, ABCD approach. That is the airway. You have to secure airway first. You have to check the breathing pattern. You have to assess the circulation, the disability, and the exposure. And you have to conduct by giving the high flow oxygen to the patient. You have to put 2 large bore intravenous cannula. You have to take the blood for cross matching. And along with that, you have to take blood for some lab tests. You can check the hemoglobin, the platelet. And treat the cause. That is, if the patient is bleeding, you have to stop the bleeding. Suppose if the patient is having hemorrhagic shock, it is better to give the blood. That is the ideal resuscitative fluid. But you can also give the balanced crystalloid as well. But remind that if the patient is lost blood, the ideal resuscitation fluid is blood. So regarding some vasoactive support in a patient with shock, you can use the noradrenaline. in a patient with septic shock or a patient with a distributive shock. And the adrenaline that is used in the anaphylactic shock and in a situation of where the patient is developed some sort of cardiac arrest. And the dobutamine, that's an inotrope, and that can be used as in a case of cardiogenic shock. And it's always give this vasoactive drug through the central axis. That is, you have to insert the central venous line. That is, you are inserting a catheter into the central veins. That could be the subclavian vein or the internal jugular vein or the femoral vein, etc. And obviously, you have to give these vasoactive drugs in a ITU setting. So the key pearl is fill the tank before you squeeze it. Suppose a patient is experiencing the hypovolemic shock due to hemorrhage, you have to replace the blood first before starting the vasopressors. So the hemorrhagic shock, you have to give the fluid and the blood before starting the vasopressors. So that is a key point. Then something about the sepsis. The sepsis means there is a life-threatening organ dysfunction from a dysregulated response to the infection. So there is a Q-SOFA scoring. That is a sequential organ failure assessment. 3 parameters are considering, that is the respiratory rate, the mental status, and the systolic blood pressure. If the respiratory rate is more than or equal to 22, you can give as a 1 point. If the Glasgow Coma scale, that is less than 15, you can give 1 point. And if the systolic blood pressure is less than or equal to 100, you can also give 1 point. So this is just to assess sepsis condition, that's a Q-SOFA score. The more than or equal to 2 means that a patient is having higher risk of the mortality. So the septic shock means the patient is having sepsis and the patient is requiring vasopressors to maintain the mean arterial pressure more than 65. And the patient is on persistent hypotension or lactate is more than 2 in spite of giving IV fluid. This condition is called the septic shock. So septic shock means the patient is having sepsis, the patient is requiring vasopressors to maintain the mean arterial pressure above 65, and the patient is having persistent hypotension or lactate is more than 2 despite giving IV fluid. So that is septic shock. So any infection with new organ dysfunction, you have to consider it as a sepsis. Don't wait for the hypotension to develop. So this is about the sepsis 6. Any patient with sepsis, you have to act accordingly within the 1 hour. This is called the sepsis 6 bundle. Consists of 6 parameters. So always remember, you have to take 3 parameters from the patient and you have to give 3 parameters, 3 things to the patient. All should be given within the first hour. So what are the things you have to take from the patient? That's the blood culture. So always consider taking blood culture before starting any antibiotics. Second one is the you are taking blood from the patient to examine or to check the blood lactate level. As I previously told, that is a marker of the hypoperfusion. And finally, you have to look or you have to measure the urine out. You can put this urinary catheter and you have to monitor the urine output hourly. So these are the 3 things you have to take from the patient. That is a blood culture, lactate, and the measuring of the urine output. What are the things you have to give to the patient within 1 hour? You have to give the high flow oxygen to maintain the target saturation between the 94 to 98%. You have to give the intravenous fluid. You can give the bolus dose of balanced crystalloid, that is around 250 to 500 ml. Then you have to give the IV antibiotics. So whenever you are saying IV antibiotics in any station, applied surgical science station, you have to mention, I will give the antibiotic according to the local trust policy. Okay, so always say like this, I will give the intravenous antibiotics according to local trust policy. So this is very important part, that is a sepsis 6 bundle. So any patient with sepsis, within 1 hour, you have to take 3 from the patient, that is a culture, lactate and urine output measuring. And 3 things you have to give to the patient, that is the high flow oxygen, the intravenous antibiotics according to local trust policy, and the intravenous fluid. Then comes the source control and antibiotics. Suppose if the patient is having some sort of abscess. Abscess means it's a collection of the pus in a wall of fibrous tissue. The source control is important. If there is an abscess, you have to drain or you have to remove that pus or collection. And in some condition, you may have to debride the devitalized tissue. Suppose a condition of gas gangrene or a condition of necrotizing fasciitis, the skin and the subcutaneous tissues become dead or sloughed. You may have to debride. You may have to debride or you have to remove the devitalized tissue. That is called the debridement. Sometimes the source of infection could be from the infected central line or some devices. Suppose a patient is on central venous line and the patient is developing some sort of fever. You have to consider this central venous line as a source of infection. You have to remove that central venous line if that is no longer required. Sometimes the source of sepsis could be from the maybe due to some sort of obstruction. The obstruction could be at the different parts, could be the biliary level. Suppose a patient is having a stone in the common bile duct that may be originated from the gallbladder. The patient is developing obstructive jaundice due to obstruction of the bile flow by stone. So that can cause the bacterial proliferation in the biliary system. That condition is called the cholangitis. So immediately the patient require the drainage of the bile. That is the patient requiring ERCP, endoscopic retrograde cholangiopancreatography. Similarly, the obstruction can be developed in the bowel. Suppose a condition of where the patient is experiencing some sort of intestinal obstruction. Maybe the small bowel is obstructed, that is small bowel obstruction. Could be the large bowel obstruction. the patient is experiencing sepsis. So the relief of the obstruction is very important. You may have to take up the patient for emergency surgery, that is exploratory laparotomy, to relieve that obstruction of the bowel. So remind that always you have to treat the source. So regarding the antibiotic principles, in any sepsis condition, you have to give the broad spectrum antibiotic first. That is, you have to say, I will give the antibiotics according to the local trust policy. And then before taking antibiotics, obviously I have already told you have to take the blood culture whenever possible. Sometimes you may have to escalate or de-escalate the antibiotics depending upon the culture report. And you have to review the patient frequently. The key point is the antibiotic treats sepsis, but the source control cures it. The abscess must be drained. So anywhere in the body, if there is an abscess that is causing the sepsis or septic shock, you have to drain that abscess, regardless of the site. So you can use some scoring system, that is the new scoring system, National Early Warning Scoring System, that is including the temperature, that considering the temperature, consciousness, the blood pressure, the heart rate, the respiratory rate, and the oxygen saturation. If the score is more than or equal to 5, that means the patient requires urgent senior review. Or if the patient's score is more than or equal to 7, that means the patient requires some aggressive critical care management. So the ABCD approach I have already described. A means airway, B means the breathing pattern, breathing, C means the circulation, D means disability, E means exposure. In A, you can constrain some, you are checking that whether the airway is patent. You can ask the patient, you can talk to the patient if the patient is conscious. If the patient is talking properly, that means the airway is patent. So you can consider in some sort of maneuver, that is a jaw thrust or chin lift maneuver, if the patient's airway is not properly secured. In breathing, you have to inspect the patient's chest. So what is the respiratory movement of the chest? If it is moving, if the chest wall is moving equal on both sides, if there is an abnormal movement in any part of the chest wall, you can examine, you can look, and also you can look whether the patient is using some accessory muscles of respiration. And you can check the oxygen saturation of the patient. And obviously you have to auscultate the patient, whether the air entry is equal on both sides and also in all important areas of the chest wall. In circulation, you can check the pulse rate, you can measure the blood pressure. You have to put 2 large bore IV cannula, and you have to give the IV fluid initially as a bolus dose, that is a 250 to 500 ml. Then according to the urine output and blood pressure, you can give the further, you can decide the how much fluid is needed furtherly. And in disability, you have to look the Glasgow Coma Scale, that include the 3 parameters: eye opening, verbal response, and motor response. You have to check the pupils, whether the pupil is, what is the size of the pupils, and also whether the pupil is reacting normally on both sides to the light. Obviously, you can check the random glucose level, random blood sugar. The expose, E means there is exposure. You have to expose the patient completely. Sometimes the injury site may be masked. Suppose if the patient might be having some sort of contusion in the flank following an RTA. Unless you are looking it, you may miss that finding. And the temperature is also important, because the patient might be in hypothermia or the hyperthermia. You may have to react accordingly. So the key pearl is don't move past a problem in ABCD until it is correct. So always you have to approach the patient in ABCD manner. That is, the airway comes first. So before assessing breathing, you have to check the airway, whether it is patent or not. So this is about the ATLS primary survey in a trauma patient. That is ABCDE. A means the airway. In a trauma setting, you have to consider the cervical spine also along with the airway. Breathing and ventilation. The C means the circulation and hemorrhage control. D means disability. You have to check the pupils. You have to look the Glasgow Coma scale. So what is the minimum Glasgow Coma scale score? That consists of 3 parameters: eye opening, the verbal response, and the motor response. So the minimum score, GC score, is 3. That is, each eye opening, verbal, and motor, the minimum response is 1. So the minimum GCS score is 3. The maximum score is 50. So eye opening, the total score is 4. Verbal response, the total score is 5. And the motor response, the total score is, or the maximum score is 6. So in a normal patient, the GCS will be 15 out of 15. So the minimum GCS is 3 out of 15. So the exposure and environment already described. And in any patient with trauma, you may have to use some adjuncts that include the blood test, the hemoglobin or the packet cell volume. You have to consider some X-rays. So any trauma patients, you may, suppose a patient is suspecting some chest trauma, you have to consider the chest X-ray. Similarly, if the patient is having some pelvic injury, you may be considering the pelvic X-ray also. The fast that we are describing subsequently. So the key pearl is that treat the greatest threat to the life first. The reassess from A after every intervention. So there are certain immediately life-threatening chest injuries. First one is the tension pneumothorax. So the tension pneumothorax. So there are certain facts you have to consider, you have to understand about the tension pneumothorax. The tension pneumothorax means it's a special type of pneumothorax in which on each inspiration, the more and more air is accumulating in the pleural space, and that is compressing the heart and mediastinal structures. So that is in a very emergency condition. So this should be diagnosed clinically. There is no need to wait until the chest X-ray reveals tension pneumothorax. So what about the immediate management of the tension pneumothorax? The needle thoracostomy. You have to insert the needle. You can insert in different position. One is the second intercostal space, And the recent guidelines state that you can also insert in the fourth or fifth intercostal space with the anterior axillary line. So that is initial management of the tension pneumothorax. Then comes only the intercostal tube drainage placement. So first, in a patient with tension pneumothorax, you have to clinically diagnose it. Then you have to consider the needle thoracostomy. Then only you have to put the intercostal drainage. That is a definitive management. So massive hemothorax means if you're inserted a chest tube, that is intercostal tube, and upon inserting it will drain around more than 1500 ml of blood, that is more than 1.5 liter. That means the patient having massive hemothorax. Or you can call massive hemothorax if the patient is having more than 200 ml of output in last each hour for 3 to 4 hours. That is, after inserting intercostal tube, if the patient is losing more than 200 ml of blood in the first hour, and again the second hour, patient is again losing 200 ml of blood more. Similarly, for the 3 to 4 consecutive hours, on each hour if the patient is losing more than 200 ml of blood, you can call it as a massive hemothorax. The open pneumothorax, the management is you have to, that is usually through a wound sustained the chest wall, you have to close that wound. You have to seal that wound using a 3-sided dressing. You have to keep the one side is open. So what about the cardiac tamponade? Cardiac tamponade, that is you will get the Beck's triad, that is a muffled heart sound, hypotension, and the raised JVP. So that is the cardiac tamponade. So what will be the treatment of the cardiac tamponade? That is a pericardiocentesis. It is the immediate needle pericardiocentesis. That is a treatment of cardiac tamponade. So regarding something about the circulation, hemorrhage, and fast. Suppose if the patient is experiencing some sort of trauma. Suppose if the patient is having some external wound. So how will you control the hemorrhage? Suppose that wound is actively bleeding. You can control the hemorrhage by applying direct pressure of that bleeding area. And also you can use some sort of tourniquet if the source of the hemorrhage is from the limbs. And similarly, suppose if a patient is sustained some pelvic trauma, and suppose if the patient is having hemorrhagic shock, so you have to consider the blood might be lost in different areas, including the chest cavity, the abdominal cavity, the pelvis, or from the long bones. So these are the areas in which the patient might lose blood. So what do you mean by FAST? That is a focused assessment with sonography in trauma. So that is the initial assessment in any patient with trauma. You are assessing the presence of blood in the abdominal cavity. That is the perihepatic, perisplenic, the pelvic area, and also in the pericardium. Now we are called it as an extended fast because you are checking the pleural cavity also. So this is very rapid bedside and repeatable scan or imaging tool. That means there is some intra-abdominal bleeding. Suppose if the patient is an unstable patient, you should not wait for the CT scan. You have to take the patient immediately into the operation theatre. So any patient with history of trauma, positive fast, and the unstable vitals. So you're starting from the fast scan. So that is to detect the free fluid in the perihepatic, perisplenic, pelvic or pericardial area. So any patient with positive fast scan and the patient is unstable, that means you have to take the patient immediately to the operation theatre. So no need to wait for the CT scan. Suppose a patient is having positive fast and the patient's vital is stable and the patient is sustained some sort of abdominal injuries. Obviously, you can consider CT scan for further evaluation. Okay, so you have to understand this point. There is a positive fast scan in a patient with unstable vitals. Always you have to directly take the patient to the operation theatre. So that is a key pearl. There is a positive fast in a hemodynamically unstable patient means laparotomy. That is not a CT scan. So something about the massive transfusion protocol and the lethal triad. So the lethal triad in trauma that is a triad of the hypothermia, acidosis, and the coagulopathy. These three act as a vicious cycle. So these three feed each other in a vicious as a cycle, and you have to break the cycle. You have to keep the patient warm. That is to prevent the hypothermia. You have to stop the bleeding. You have to correct the clotting parameters. So in a patient with trauma, that is patient trauma along with the hemorrhagic shock, you have to initiate the major transfusion protocol. That is always you have to transfuse in a balanced ratio. That is the 1:1:1 ratio. You have to give the PRBCs, that the packed red blood cells, the fresh frozen plasma, and the platelet in a ratio of 1:1:1. You can give the tranexamic acid initially. You can give the 1 gram intravenous tranexamic acid in any patient within 3 hours of trauma. And always you have to keep the permissive hypotension until the bleeding is cut. Suppose a patient is having hemorrhagic shock and you are resuscitating the patient. And during resuscitation, if the patient's blood pressure is raised, suppose in an example, patient's blood pressure is raised around 140 systolic blood pressure and the 90 diastolic blood pressure. That means the patient's blood pressure is increased. That can further aggravate the bleeding because blood pressure is more. So you only require some permissive hypotension. Permissive hypotension means the hypotension that is at the level of some level supply, the adequate blood supply to the vital organs. And you have to keep the patient warm. You have to correct the calcium level. Suppose if you are giving multiple transfusions, the patient might be experiencing hypocalcemia. And you have to correct the acidosis parameters. You have to correct the clotting parameters also. So regarding head injury and Glasgow Coma Scale, I have already described something. That is the GCS contains 3 parameters. That is eye opening, the voice, that is the verbal response, and the motor response. The eye opening, the maximum score is 4. The verbal response maximum score is 5. The motor response maximum score is 6. So the maximum score a patient is having, a normal patient is having, is 15. The minimum score is, each of these having 1 score minimum. So the minimum score will be 3 out of 15. Suppose if the patient's GCS score is less than or equal to 8, that means you have to secure the airway by you have to intubate the patient. The raised intracranial pressure that can cause the Cushing's response, that is hypertension, along with the bradycardia. In any patient with head injury, you have to avoid the hypoxia and the hypotension because these two can cause the secondary brain injury. You have to consider the CT head. CT head might reveal some sort of bleeding, could be extradural hemorrhage, could be subdural hemorrhage or subarachnoid hemorrhage, or it could be some intraparenchymal hemorrhage also. In an extradural hemorrhage, you will get the lucid interval. The patient might lose some consciousness, and after some period, the patient regain the consciousness, and the patient again will lose the interval. That is typically you are getting in an extradural hemorrhage case. So the key pearl is, if the patient's GCS is less than or equal to 8, always intubate the patient because the secondary brain injury from the hypoxia and hypotension kills the patient. So you have to prevent the both. So what about the compartment syndrome? So the compartment syndrome could be in the limb or could be in the abdominal compartment. So how will you identify the limb compartment syndrome with the limb? Suppose a patient is experiencing having some sort of trauma, followed that the patient is developing some swelling in the compartment, swelling of the leg. So there are 6 P's: the pallor, pulselessness, paralysis, the poikilothermia, the pain. So remind that the pulselessness is a late feature. So what could be the earliest feature? The pain out of proportion and also the pain on the passive stretch. These are the earliest finding in a case of compartment syndrome involving the limbs. That is, the compartment pressure is more than 30 to 40 millimeter mercury. So what could be the treatment of the compartment syndrome? You have to release the compartment pressure. So you require emergency fasciotomy. So what about the abdominal compartment syndrome? That means the pressure in the intra-abdominal compartment is rising. That is, the intra-abdominal pressure is more than 20 millimeter mercury along with the features of organ dysfunction. You can diagnose the abdominal compartment syndrome. You can measure the abdominal compartment pressure by measuring the bladder pressure. Increasing abdominal compartment pressure can cause the oliguria, or it can push the diaphragm up and it can cause the raised airway pressure. So what could be the treatment? You can consider the decompressive laparotomy. So the key point is the pain on passive stretch is the earliest sign of compartment syndrome involving the limb. Never wait for pulselessness. By that time, the muscle may be dead. Something about the acute pancreatitis. So what are the causes of acute pancreatitis? You can remember the mnemonic I get smashed. That is idiopathic, gallstone, ethanol, steroids, mumps, autoimmune causes, scorpion bite, hypercalcemia and the hypertriglyceridemia, and the post-ERCP. And finally, there are certain drugs that can induce the pancreatitis. So severity you have to assess by different scoring system. The Ranson scoring system is there. The modified Glasgow scoring system is there. That is considering the different parameters like the PaO2, age, calcium, the urea, the liver enzymes, etc. Also, there are certain scoring system called the CR. You can measure the C-reactive protein level in the blood. There is one more scoring system, that is the Apache 2 scoring system. If the score is more than 3 or more, that means the patient requires some HDU or ITU admission. Among these, the gallstone and alcohol are the commonest causes of acute pancreatitis. You can check the blood levels of amylase and lipase. Lipase is more specific in the context of acute pancreatitis, but it doesn't grade the severity of the disease. So you can use some scoring system like the modified Glasgow or Ranson or Apache 2 scoring systems. So how will you manage a case of acute pancreatitis? You have to always say, I will manage the patient according to care of the critically ill surgical patient protocol. I will conduct the resuscitation in a ABCD approach. Then you can start different other aspects. You can give the high flow oxygen, you can give the analgesic, you can give the intravenous fluid. You have to catheterize the patient, you have to monitor the urine output. You have to consider the nutritional aspect. You can give either enteral or parenteral nutrition. The enteral nutrition is preferred. Better to give the nasovaginal feeding or nasoduodenal feeding, because the pancreas will become edematous. It can compress the gastric outlet. And obviously you have to treat the cause. If there is the etiology of the pancreatitis due to gallstones, you may have to do the immediate ERCP to relieve that obstruction, and followed by you have to do the cholecystectomy also. So what are the complications of acute pancreatitis? The pancreatitis complication could be local complication or the systemic complication. The local complication means anything related to the pancreas or any surrounding aspect of the pancreas. It could be some acute fluid collection, it could be some pancreatic necrosis, could be pseudocyst, etc. The systemic complication could be systemic inflammatory response syndrome, multi-organ dysfunction syndrome, acute kidney injury, hypovolemia, or ARDS. These all are the systemic complication. There is one local complication that is called the pseudocyst. Pseudocyst means it is a collection of the amylase-rich fluid enclosed in a wall of fibrous or granulation tissue that is around the pancreas. Usually that will take around 4 weeks from the onset of the acute pancreatitis to develop the pseudocyst. So any pseudocyst that is lasting for more than 6 weeks, or if the pseudocyst size is more than 5 centimeter, or if the patient, you have to treat that pseudocyst. So what is the treatment of the pseudocyst? That is internal drainage. You can open the cyst wall and that is drained into jejunum or duodenum or into the stomach. That is called the cystogastrostomy, cystoduodenostomy or cystojejunostomy respectively. So that is the treatment of the pseudocyst. So remind that the infected pancreatic necrosis, that is the main cause of late death. So you have to suspect that in a patient. Suppose if the patient is deteriorated after the first week, or you have to suspect infected pancreatic necrosis. Coming to postoperative pyrexia. So any patient with any post-operative surgical patient, the patient can develop fever. The cause of fever could be different. You will get a clue regarding the cause of the fever depending upon at what post-operative day the patient developed a fever. Within 24 hours, the cause could be the tissue trauma due to handling during surgery, or maybe due to some atelectasis. Suppose if the patient is underwent surgery in general anesthesia, the post-operatively, due to the pain, the patient will not breathe properly or ventilate properly, and the alveoli will become collapsing, and it collapsed state, and it can cause atelectasis. That is the collapse of the alveoli. In 1 to 3 days, the cause could be the pneumonia, and again the atelectasis also. Within 3 to 5 day post-operatively, you have to consider the urinary tract infection or any other catheter-related infection you have to consider. In a post-operative day 5 to 7, you have to suspect any wound-related problem. Could be some wound infection or wound-related collection. In after day 5, you can also consider the deep venous thrombosis as a cause of post-operative pyrexia. So the timeline, you can remember the mnemonic: the wind, water, wound, walking, and the wonder drugs. The timeline points you to the likely cause of the post-operative fever. So what about the venous thromboembolism, the DVT and pulmonary embolism prophylaxis? So how will you recognize a case of DVT? That is a deep venous thrombosis. A unilateral swelling of the calf, and the patient is having calf muscle tenderness. That is a case of deep venous thrombosis. Obviously, this deep venous thrombosis can cause pulmonary embolism. So what will be the clinical features? The patient is experiencing some sort of pleuritic pain or dyspnea. On evaluation, the patient's heart rate will be increased, that is a tachycardia, and the oxygen saturation will be low. So tachycardia and decreased oxygen saturation with dyspnea. In a post-operative patient, you have to think about the pulmonary embolism. So how will you confirm a case of deep venous thrombosis involving the limb? Obviously, you can consider the Doppler scan. So how will you confirm the pulmonary embolism? You have to take the CT pulmonary angiogram. There is one triad that is called the Virchow's triad, that is about the causation or about the risk factors of deep venous thrombosis. That is a stasis of blood, endothelial injury, and the hypercoagulability. These three included as a Virchow triad of the deep venous thrombosis. So how will you prevent the occurrence of deep venous thrombosis in a surgical patient? You have to assess the risk of developing deep venous thrombosis in every surgical patient. You can use different types of scoring system. And there are certain mechanical methods in which you can prevent the DVT. That is thromboembolic deterrent stockings, that is the TEDs. And you can use some sort of intermittent pneumatic compression devices. You can apply simple elastogrip bandages into the limbs. So these are the mechanical prophylaxis. And obviously there is some pharmacological prophylaxis as well. You can give the low molecular weight heparin. That is, if the patient's bleeding risk is low, you can give low molecular weight heparin. And the early mobilization following surgery is very important aspect to prevent the deep venous thrombosis. So how will you treat a pulmonary embolism case? In a patient with deep venous thromboembolism, developed pulmonary embolism, the patient hemodynamically could be stable or unstable. Suppose if the patient is stable, hemodynamically stable, you can anticoagulate the patient. If the patient is hemodynamically unstable, you have to consider thrombolysis. So this is a basic dictum of management of pulmonary embolism. Patient is hemodynamically stable, you can anticoagulate. If the patient is hemodynamically unstable or in instability, you have to consider thrombolysis. So something about ileus versus mechanical obstruction. In a post-operative patient, suppose a patient is underwent some sort of laparotomy. Post-operatively, the patient might develop some sort of abdominal distension. It could be either a mechanical obstruction or maybe due to some post-operative paralytic ileus. So how will you distinguish? One is based upon the bowel sound that is absent in paralytic ileus, that is high-pitched or tinkling in mechanical obstruction, but the bowel sounds may become absent in the late stage of mechanical obstruction also. The distension, the patient is having mild distension, and also the patient's pain is mild. In a case of mechanical obstruction, the patient is having some sort of colicky pain. The onset, paralytic ileus that can occur in post-operative patient, especially having some metabolic abnormalities like hypokalemia or hyponatremia. The mechanical obstruction could be maybe due to hernia, bowel tumor, or adhesions. The adhesions are the one of the most commonest cause of mechanical bowel obstruction. So X-ray in paralytic ileus reveal the generalized gas. In mechanical obstruction, that will reveal the dilated bowel loop along with multiple air fluid level. So post-operative paralytic ileus is usually self-limiting. You can put some nasogastric tube and you can aspirate, and you have to correct the coagulation. You have to correct the electrolyte imbalance, especially the potassium, and you have to treat the cause accordingly. The exam tip is the adhesions are the commonest cause of small bowel obstruction in the operated abdomen. So regarding the collection and anastomotic leak, so any patient who underwent some gastrointestinal anastomosis can develop anastomotic leak. That is usually manifest in the post-operative day 5 to 7. The patient is having tachycardia, the pyrexia, the pain, and ileus. So how will you suspect the anastomotic leak? If the patient is deteriorating clinically, or if the patient's total count or C-reactive protein is rising in the post-operative period, you have to suspect the anastomotic leak. So how will you confirm the anastomotic leak? Obviously, you have to consider the CT scan with contrast. That is contrast enhanced CT scan. Obviously, there is some contrast leak at the site where the anastomotic is leaked. And you have to resuscitate the patient, and you have to give the antibiotics according to local trust policy. The most of the situation, you have to re-operate, or you have to take the patient again into theatre for a re-laparotomy. So how will you suspect intra-abdominal collection? Post-operative period, post-operative patient with singing pyrexia, with raised inflammatory markers, you have to suspect intra-abdominal collection. So how will you address or how will you manage that intra-abdominal collection? You have to drain under image guidance, and you have to escalate the problem early. So the key pearl is the tachycardia is the earliest and the most consistent sign of anastomotic leak, and you have to take it as a seriously, and you have to address. So regarding the wound complications, it could be the surgical site infection. So any patient with some sort of discharge in the post-operative period from the surgical wound, there is a surgical site infection. The locally on examination, you will get some sort of erythema around the wound. You have to open the wound and you have to take the swab for the culture and sensitivity, and you have to start the antibiotics according to local trust policy. Anywhere in the hematoma or seroma, you can compress and you have to drain if the patient is symptomatic. Any anastomotic dehiscence? you have to take this. You have to in a case of wound complication, that is the wound dehiscence. Suppose if the full thickness wound dehiscence, you have to take the patient into the theater, and you have to consider the resuturing. The incisional hernia is very late complications following surgeries. The risk factors could be previous wound infection, the obesity, the improper technique or improper suture material used. These all can act as a risk factors for incisional hernia. A sudden pink serous discharge from a laparotomy wound with some dehiscence. You have to resuscitate the patient, you have to cover that area, and you have to return the patient back into theater, and you have to resuture. The nutrition and refeeding. The route is the enteral route whenever the gut works. If the gut works, use the enteral route. That is, you have to protect the mucosa. If enteral nutrition is not possible, you have to consider the total parenteral nutrition. That is, you have to put the central venous line, and you have to give the nutrition through the central venous route. So what about the refeeding syndrome? Suppose in a malnourished patient, if you started feeding in an aggressive manner, it can cause the fall in phosphate, potassium and magnesium level. So always consider you have to refeed very slowly, replace the electrolytes and give the thiamine first. So what about the acute kidney injury? It could be pre-renal, renal or post-renal causes. The pre-renal means the hypoperfusion. So any injury at the renal level that can cause the acute kidney injury, like acute tubular necrosis, the contrast-induced renal injury. There are certain drugs that can act as a nephrotoxin and cause kidney injury. The post-renal, any sort of obstruction. Suppose a stone is blocking the ureter, that can cause post-renal kidney injury. So how will you manage? You have to treat the cause, you have to optimize the volume, you have to measure the blood pressure, you have to stop the culprit drugs, suppose the NSAIDs, ACE inhibitor or gentamicin, you have to stop. You have to monitor the potassium and fluid balance. In a patient with a refractory acute kidney injury, that is, the patient has developed acidosis or increased potassium, you may have to consider the dialysis. So most surgical AK is pre-renal from the hypovolemia. You have to restore the perfusion and you have to review the drug chart first. That's a very important point. That is acute kidney injury in a post-surgical patient. That may be due to hypovolemia. So the respiratory failure and ARDS could be a type 1 or type 2 respiratory failure. So the type 1 is hypoxic respiratory failure. Type 2 is the hypercapnia, the respiratory failure to hypercapnia. That is the high CO2. That's a type 2 respiratory failure that is seen in chronic obstructive pulmonary disease, the opioid intake, etc. The type 1 is hypoxia. The pulmonary failure is due to hypoxia. That is due to the pneumonia, pulmonary embolism, pulmonary edema, etc. And the ARDS, that is due to the diffuse alveolar injury, could be due to different causes, could be due to sepsis, the pancreatitis, or due to trauma. In ARDS, the patient is developing acute hypoxemia along with the bilateral infiltrates in the chest that is not explained by a cardiac failure. That is the ARDS. You have to treat the cause and you have to ventilate the patient. That is the lung protective ventilation. So the transfusion burns and glycemic control. The transfusion, you have to, already I described, you have to follow a massive transfusion protocol. That is 1:1:1 ratio. If you are transfused, you have to look for some complication related to transfusion. That is a transfusion associated cardiac overload or the transfusion related acute lung injury, that is the TRALI. So massive transfusion, again, it can cause the hypocalcemia and you have to correct the calcium. In burns, the resuscitative fluid you can calculate based upon the Parkland formula, that is 4 into total body surface area into weight of the patient. That gives the amount of fluid that is required in the first 24 hours. You can give the half of the fluid in the first 8 hours, followed by the rest half of the fluid in the next 16 hours. And always you have to watch the airway in a patient with facial burns. In the glycemic control, you can give, you have to avoid the hyperglycemia. You may have to stop the metformin if the patient is having risk of acute kidney injury. You can give, in a patient, if you are planning for surgery, you have to change the oral hypoglycemic into the insulin level. The key pearl is the Parkland formula in the burns that gives the amount of crystalloid required for the first 24 hours. That is from the time of the burn, not from the time of arriving the patient into the emergency department. It is from the time of burn itself. So you have to titrate the IV fluid based upon, you have to maintain the urine output minimum of 0.5 ml per kg per hour. So this is about the 3-month course, that is MRCS Part B general surgery. That is starting from the September 2026. That is a 3-month regular course. And what you will gain is the intensive station, the expert-led guidance on exam technique and performance, the mock circuit designed to simulate the real exam. So we are going to discuss some question and answer section. Suppose a patient, post-operative patient, has heart rate 130, BP is 96/70, the respiratory rate is 24, and the lactate is 4.2, and the patient has passed 15 ml of urine in the 2 hours. What is your first action? What does the lactate indicate? Outline your immediate management. When would you escalate? Here, you can look, the heart rate is 130, that is the patient is tachycardia, hypotension, respiratory rate is increased, and the lactate is also increased, and the urine output is low. So what is your first action? Yes, obviously, you have to manage according to care of critically ill surgical patient protocol. You have to follow the ABCDs assessment. So this is a shock patient. The raised lactate, that means patient is having tissue hypoperfusion. You have to give high flow oxygen, 2 large bore IV cannula. You have to take blood for labs, and you have to for cross matching. You can give a initial bolus dose, that is a 250 to 500 ml crystalloid. You have to reassess. You have to find and treat the cause, whether it's a hemorrhagic or septic shock. You have to find and escalate early to senior, or you have to construct the ITU, admission into ITU. So this is an ABG with pH is 7.21 and PaCO2 is 3 kilopascal. The bicarbonate is 12 and the lactate is 7. Name the acid-base disturbance. Is there any compensation? Give the surgical likely cause and your first management step. Here the pH is 7.21. So that means the patient is having acidosis. The bicarbonate is low and the PaCO2 is also 3. So bicarbonate is low, that means the patient is having some metabolic problem. And the CO2 is also low, that means some sort of respiratory compensation, and the lactate is elevated. So that means low pH, acidosis, low bicarbonate, that's a metabolic problem, that is a metabolic acidosis. CO2 is low, so that is a respiratory compensation. The higher lactate level means that is a patient is having hypoperfusion. It could be hemorrhagic shock or some ischemic bowel. So you have to resuscitate according to ABCD and you have to find the source of the lactate. A trauma patient is hypotensive, distended neck veins, muffled heart sound, and tracheal shift. So name the diagnosis, name the triad. What is immediate management? How does that differ from tension pneumothorax? So what is the condition? That is called the cardiac tamponade. That is the Beck's triad. You will get the muffled heart sound, the raised JVP, and the hypertension. So what will be the immediate management? Already told, the pericardocentesis or the emergency thoracotomy is the immediate management. So the tension, how will you differentiate the cardiac tamponade from the tension pneumothorax? The tension pneumothorax also having raised JVP, but with tracheal deviation and absent breath sound. In aviation with tension pneumothorax, the trachea is deviated with the breath sounds will be absent. So both are the cause of obstructive shock and you have to decompass the immediate. On day postoperative 6, there is anti-resection. The patient is having tachycardia, febrile and abdominal pain with rising CRP. So that is an anastomotic leak. What is the earliest sign? There is a persisting tachycardia. So how will you identify anastomotic leak? The investigation of choice is the contrast enhanced CT scan. So how will you treat? You have to resuscitate the patient, ABCD approach. In the most of the situation, you have to take the patient back to the theatre for the real aprotomy. And obviously you have to escalate the problem to senior and ITU admission as well. Question 5, a malnourished patient with low BMI started on feeding and develops falling phosphate, potassium and magnesium. So name the syndrome, what drives it, what should be given the first, how do you prevent it? The answer is the refeeding syndrome. It is driven by the insulin surge on reintroducing the carbohydrate. So always you have to give the thiamine before with feeding, before or along with the feeding. Start feeding very slowly and replace the electrolytes. And always identify at-risk patients and monitor the electrolytes, that is phosphate, potassium, magnesium. After a tibial fracture and a long operation, the patient has severe calf pain that is markedly based on passive extension of the toes and the pain is out of proportion to the injury. So patient is having tibial fracture and a long operation, severe calf pain. And you have to look the keyword, that is the pain that is worse on the passive extension, that is out of proportion. That means it's a compartment syndrome. So what is the earliest sign? That is a pain on passive stretching. The pulselessness is a late feature. The confirmation that you have to measure the compartment pressure. The treatment is emergency fasciotomy. There should not be any delay for doing fasciotomy. So this is about some experience you will get before attempting MRCS Part B General Surgery, September 2026. There is a 2-day live on-site course. And you have to register, try to register for this. And the key points you have to note is never diagnose before you resuscitate. Never wait for chest X-ray to treat a tension pneumothorax. Never correct the sodium rapidly. You have to never order a CT scan in an unstable patient with positive fast. So you have to always start ABCD and call for help. You have to decompress the tension pneumothorax clinically. Do not wait for chest X-ray. Correct electrolytes slowly. And always give insulin dextrose to shift the potassium in a hyperkalemia patient. Treat the tachycardia as an indicator of anastomotic leak until proven otherwise. Take the unstable fast positive patient directly into the theatre. The resuscitation fluid always open with ABCD and call for help. The maintenance fluid is 25 to 30 ml per kg per day. Crystalloid bolus 250 to 500 ml. The calcium is stabilizing the heart but doesn't lower potassium in a case of hyperkalemia. The potassium won't correct until the magnesium is replaced, and the correct sodium slowly, that is less than 8 to 10 millimole in a 24-hour period. Rising lactate is the indicator of hypoperfusion. Anion gap, that is a measured cation minus measured anions. The blood pressure falls late in a hemorrhagic shock, so watch for the high heart rate. Surgical shock, you have to consider it's a hemorrhagic shock until proven otherwise. Always in a hemorrhagic or hypovolemic shock, you have to give the proper fluid first or the blood first. Then only you have to add the vasopressors if the patient is still in hypotension. Based on the extremities, whether it's a warm or wounding, it could be septic shock. If the extremity is cold and thready pulse, it could be hypovolemic shock. Sepsis 6 bundle, that is within 1 hour, 3 take, 3 gives. Always control the source, and the antibiotics you have to give according to local trust policy. The tension pneumothorax, that's a clinical diagnosis. You have to decompress immediately. Unstable patient with positive fast theatre, you can give the tranexamic acid within 3 hours. Any patient with trauma with GCS score is less than or equal to 8, you have to intubate. The tachycardia in a post-operative patient, you always suspect anastomotic leak. The post-operative pyrexia, you have to think that different possibilities according to the day in which patient experienced fever. The pink serous wound discharge could be indicator of wound dehiscence. The most surgical acute kidney injury is pre-renal. The refeeding syndrome, always watch phosphate and other electrolytes. The acute pancreatitis, the amylase and lipase confirms the diagnosis, but always you require some scoring system like Ranson, the modified Glasgow or Apache 2 scoring system to create the severity. The muffled heart sounds, raised JVP, hypotension, that's a cardiac tamponade, that's Beck's triad. The tall tender T waves on ECG, that's hyperkalemia. Post-operative after day 5, patient experiencing pain, pyrexia, tachycardia pain, could be anastomotic leak. Falling phosphate after starting feed, it could be a refeeding syndrome. Tracheal deviation along with absent breath sound, that is a tension pneumothorax. The high lactate, the low bicarbonate, low carbon dioxide, that's a high anion gap metabolic acidosis. Hypertension, bradycardia in head injury patient, that is the Cushing's response, that is due to raised intracranial pressure. Pink serous discharge from a laparotomy wound, that is wound dehiscence. Any unilateral cough swelling, that is tender, that is indicate the DVT. The singing pyrexia, raised CRP postoperative, intra-abdominal collection. The signs related to hypocalcemia, that is a Troche sign and Chopstick sign. Acute pancreatitis, there is a raised amylase and lipase along with fat necrosis. There is some recall scenario. The abdominal aortic aneurysm repair, 70-year-old, long, difficult operation. The core temperature is less. The examiners will be asked the effect of hypothermia here. It will impair the clotting enzymes, coagulopathy, arrhythmia, etc. The same case, how do you avoid intraoperative hypothermia? You have to warm the theatre, you have to use the warm IV fluids. You have to forced air warmer, warm irrigation, minimize the exposure and operative duration. Significant blood loss, massive transfusion, how will you define? More than or equal to 1 blood volume in 24 hours or more than 4 units in 1 hour. That define the massive transfusion. What are the complications? List them. The TAC, that is transfusion associated cardiac output overload. The TRALI, that is transfusion associated lung injury. The hypothermia, hypocalcemia or hyperkalemia can occur. If abdominal aortic aneurysm ruptures, which organ becomes ischemic? The kidney, gut, The lower limb and spinal cord will not get proper blood supply. Crush injury or rhabdomyolysis. What will be the pathology? The rhabdomyolysis can cause the myoglobin that is released into circulation, can cause acute kidney injury. ABG is acidotic, raised lactate. Which blood parameters you have to check? The creatine kinase, the lactate, urine examination, urinary myoglobin you have to check. The worsening pain in the leg, that's a compartment syndrome. It's a pain on passive stretch, out of proportion, 6 P's. Late feature is a pulselessness. How will you manage compartment syndrome? The emergency fasciotomy, do not delay. What is the renal protection? In rhabdomyolysis, you have to aggressive IV fluid, monitor and treat the hyperkalemia. Steroid additional crisis and deteriorating patient. Post is preoperative esophagectomy, rheumatoid arthritis on long-term steroid. The patient can develop Addisonian crisis. So give intravenous steroid at induction and double in the perioperative dosage. How would an Addisonian crisis present? The patient will present the features of shock, abdominal pain, confusion, vomiting, and the electrolyte imbalance like the hyponatremia and hyperkalemia. So what are the ECG findings in hypokalemia? The T wave will be flat, U waves, ST depression, prolonged PR. The same patient examined as well the cause and initial management, likely perforation. Central, you have to take this central line for rapid potassium correction, cardiac monitoring. Consider, you have to give the IV fluids and you have to consider surgery. Septic patient with irregular pulse, ECG changes, new atrial fibrillation. POD1, the urine output is low, tachycardia, narrow pulse pressure. Could be assessment hypovolemia. You have to initially fluid challenge, reassess CVP measurement. 30-year-old pregnant patient, BP is low. So what could be the contributing factors? Intraoperatively, the hemorrhage, the aortocaval compression, the involved the obstetrician and the anesthetic also. The same case, preload cardiac output, preload and cardiac output. Fluid first, that is a preload, you have to increase, then inotropes. Hypotensive man, TURP, hyponatremia diagnosed, the TURP syndrome, that is the due to the glycine absorption, patients having risk of seizure and coma. Classify the shock in a surgical patient, types of shock. We have already described the hypovolemic, distributive, cardiogenic, and obstructive shock. Trauma, pancreatitis, and burns. Polytrauma, aortic rupture, approach, ATLS, major transfusion protocol. Okay. Rotoreflex action, pneumothorax plus rigid abdomen. How will you confirm the intraabdominal bleeding? The first, that is focused assessment, sonography for trauma. CT, if the patient is stable, unstable, directly laparotomy. Acute pancreatitis in an alcoholic patient with severe epigastric pain, mechanism of hypocalcemia, the fat necrosis that can cause the calcium saponification, that can cause hypocalcemia. The pancreatitis follow-up, what is the pseudocyst? It is a collection of amylase-rich fluid enclosed in a wall of fibrous tissue. No epithelial lining, that is, will take more than 4 weeks from the onset. Burn, then the tachypnea, shortness of breath, chest X-ray infiltrate, that is ARDS. That is you have to consider the lung protective ventilation. You have to remember the Parkline formula for fluid in a burn resuscitation. So these are the sources for further reading. Experience the exam before the exam, MRCS Part B General Surgery, one-on-one mentorship program. Limited slots are available.